and also for you to ask your questions. So as you know, today's topic is how myeloma patients are responding to the COVID-19 vaccines. Since these vaccines have arrived, the question of their effectiveness for multiple myeloma patients has been on the mind of practically everyone in this community. In almost every event that I've had, there has been some kind of COVID question that has been left unanswered due to the lack of data that was available about this subject. However, thanks to amazing physicians who've made it their mission to get answers for us, we are finally able to get a lot of the answers that we have been searching for. So it is now my pleasure to introduce two of these physicians to you today. Dr. Samir Parekh is a professor of medicine in the Hematology and Medical Oncology Department and Oncology Sciences and director of translational research in myeloma at the Tisch Cancer Institute at the Icahn School of Medicine at Mount Sinai. Dr. Parekh's research focuses on the pathogenesis of hematological malignancies and development of individualized precision medicine therapies for these malignancies. His lab uses an integrated systems biology approach to study genome-wide methylation, gene expression, and DNA sequence variation to understand pathogenesis, develop biomarkers, and guide personal therapy in B-cell malignancies, particularly multiple myeloma and non-Hodgkin's lymphoma. Dr. Oliver van Oekelen is, I'm probably butchering that, we practiced yesterday and I'm nervous, is a medical doctor trained in bioinformatics with a degree from the University of Leuven, Belgium. He has completed the first 2 years of internal medicine residency in Belgium, after which he joined the PhD in biomedical sciences at the Icahn School of Medicine at Mount Sinai in 2018. During his PhD, he is focusing on the role of non-tumor cells in the development of disease, in disease progression, and relapse after treatment. Using next-generation sequencing at the single cell level and mass cytometry, Oliver hopes to clarify the intricate crosstalk between various cell types in the bone marrow microenvironment. So as you can see, you have two very special people joining you today, and I'm really excited to turn the time over to them and listen to their presentation. Thank you both for being here today.
Thank you, Audrey. Can you hear me? And Oliver, great. So
yes,
thank you for the invitation and kind introduction. I think it's really important for you and myeloma community to be connecting us in this way. I was actually one of the initial physicians in the first wave of the COVID pandemic and experienced firsthand at Sinai when we had more than 5,000 patients admitted, that taking care of COVID patients involves a great deal of communication between the patients and patients' families that the doctors and staff need to do. And this is where organizations like Myeloma Crowd can really come in and make a difference. So I'm very grateful for you to step in this role and help us connect with the larger myeloma community. Um, I will probably try to set the stage in the first half an hour to talk a little bit about the research we have been doing, which was spurred on by the need that we felt was clinically necessary and to investigate. And hopefully this can answer some of the questions that members of the community, both patients and their families, have. And then we'll be happy to take any questions. This effort has been hugely informative to us and helped us change our practices as the pandemic has evolved in the last several months. And I'm very grateful to all the patients that have taken part in the research by giving us samples and informing us about what's going on about their vaccines and things like that. And to all the members of the team, including Oliver, who played a part in conducting this research. It wasn't just my lab, but actually the infrastructure provided by the institution and several groups of immunologists, virologists, microbiologists that all participated in understanding this disease and its impact on myeloma patients. So with that, Audrey, if I can share the screen and present some of the updates on the data, maybe that would be a
Yes.
good stepping off point. So can I ask if you can see my screen and the slides on it?
Yes.
Wonderful.
Yes.
So I'm actually going to
It's not in
give the
presentation
audience.
mode. Did you want it to be in presentation mode?
Either way, I think if
Okay.
you can
Okay.
see
I was
the
just making sure.
slides largely enough, yeah, that's fine. I
Okay.
think the important thing is, this is a conversation, and the slides are actually a preview of talk that is going to be later in November at an immunotherapy conference. This preview is intended to provide information to the participants in this conference and a source of dialogue between the participants and Oliver and us. And I think Audrey has done a great job organizing this and will be moderating the questions as they come in. So please, this is meant to be informative and informal, and ask your questions, and Audrey will be monitoring the chat and Q&A, and we will try to answer as much as we can after the few slides here. So the first introductory slide I have actually talks about why we need to study the immune response in myeloma. And this is somewhat obvious to myeloma patients and physicians, but not universally well recognized. I realized that this was the case when we had a recent paper published, and several of the questions went around a very fundamental question of why do myeloma patients have a greater susceptibility to infection or to COVID. And I think the answer lies in two aspects. One is the disease aspect. The myeloma is a disease of uh, immune cells. The plasma cells exist in all of us to make antibodies, and a cancer that affects plasma cells, although it increases one type of plasma cell, paradoxically reduces normal plasma cells and the protection that they provide by the antibodies that they make. So in a historical context, we have always seen that myeloma patients have been more prone for bacterial and viral infections because of the underlying disease. And as physicians, we actually sometimes worsen that immune suppression by giving treatments that can further impact the immunity in an effort to eradicate the myeloma. And these include non-specific immune suppressants like steroids or alkylating agent. Uh, Many of you may have heard of or received melphalan, which is a common alkylating agent type of chemotherapy, which can be immunosuppressive and induce um, an environment that promotes bacterial infection as well as other infections. More recently, we have had many exciting developments and drugs approved for myeloma that are really great against the disease, but they do have side effects because they target, again, plasma cells, which are the cells that we need to make antibodies. These are the factories of normal antibodies that we need to fight infection. A couple of examples that I've listed on the slide are the anti-CD38 antibodies, which are exemplified by daratumumab or isatuximab, and many of you all may have received these drugs for the myeloma control, but they have a side effect where they further cause immune suppression to make patients susceptible to COVID and other infections. Another exciting development that's very important for myeloma patients is the development of anti-BCMA therapeutics. And these are of two types. There's CAR T, and they are bispecific antibodies. And both of them are effective. They can help eradicate myeloma, but they also cause immune suppression in different ways. We have seen this, and I'll talk a little bit about it later on. At the time when we started this research, we knew very little about the immune response to COVID vaccination. We knew that there were some early reports which suggested that the antibody production was suboptimal and slower than healthy individuals after getting one dose of the vaccine, but it was kind of unknown what the effect of full vaccination strategies were. And that's when we started looking at this. And we were able to do this because the myeloma program at Sinai, we've been designated a center of excellence. It actually is a large program where we see amongst 9 physicians about 600 new patients every year and have a stable cohort of about 3,000 patients that we take care of. And these patients come from all over the tri-state area, not just New York. Many of them have their own treating physicians, and we act as consultants to help the treating physicians manage their patients locally. As you can see in the graphs below, we have a number of patients that go on to investigational trials as a result of this large population and the needs that they have. We frequently are able to offer them clinical therapeutics that are not yet approved but are looking promising for myeloma treatment. And we roughly used to do about 150 autologous transplants a year. In the last couple of years, as CAR T is becoming more and more popular, that number is starting to go down and the number of CAR Ts is starting to go up, which is relevant for this, as I'll show in just a second. So my personal interest in COVID and COVID research actually started right after the first wave of the pandemic, where I, along with other physicians at Sinai, had been pulled into COVID care, and we saw what the disease did to the general population of patients that was being admitted. And then we went back to our myeloma patients and started adapting the care that we were giving them to actually make it safer, avoid clinic visits into the hospital if possible, by switching patients to oral medications and things like that. Then later on in the course of the year, the vaccines became available. And I had a patient who had received CAR T and actually was cured of his myeloma from the CAR T, who had gotten 2 doses of Pfizer vaccination in an effort to make a protective immune response. And when we tested him after the second dose, he had not developed antibodies, which was puzzling. But because he had gotten 2 doses, the patient felt protected against COVID and actually went to the gym to exercise. And I suspect that's when he may have been infected with COVID, because a few days later, he actually came to the clinic with fever and shortness of breath, and we diagnosed him as having COVID infection. He unfortunately got worse, was admitted to the ICU, put on a ventilator, and passed away shortly thereafter. And this was a huge shock to all of us. Like many of our patients, he was very near and dear to the clinic staff, and we were all wondering why this happened despite both doses of vaccines being given to him. And we then further analyzed his blood, not just to confirm that he had no antibodies, but there are other protective cells that are supposed to be helping mount an immune response to COVID. And we wanted to test if these cells were there. Now, this is a plot of B cells and T cells, and we have done these studies in the patient as well as healthy individuals to compare and see what was different. And over here on the x-axis, we actually measured whether he had B cells. And here in the healthy individual, you can see they have lots of B cells. But in his case, he did not have B cells. B cells are the precursors to plasma cells, which are really important to mount antibodies. So it partially explained to us why he was not mounting antibodies. In contrast, when we looked at T cells, he did have T cells, but we have specifically designed assays for B and T cells that can actually recognize COVID. And when we looked for B cells as well as T cells that were able to recognize COVID, he had dramatically none to absent cell responses against the COVID as compared to healthy control. And non-specifically, he did have T cells against other stimuli. So this wasn't a general lack of T cells. So I want to stress that this was specifically a defect that was there against COVID. And this started us down the path of looking at what was going on in the rest of our patients in a systematic way. And Oliver led that effort. This was a large collaboration with several different labs, which was published a few months ago, where we looked at almost 300 patients that had myeloma, whether they had developed antibodies after 2 doses of COVID vaccination. And it was a very important study because we learned several things that we did not know before. The first thing we learned was that after 2 doses of vaccination, in general, myeloma patients, here we showed 260 patients, in general, they had lower antibody levels as compared to healthy controls. And about 15% of individuals had zero antibodies, absent, completely absent, which was a surprise to us. The other thing we learned, and on the right is a graph of how quickly these antibodies develop. In the white part are when you have no antibodies. You can see in healthy individuals, myeloma patients, in healthy individuals, as they got the first dose and then second dose after vaccination, they quickly mounted antibodies. But the myeloma patients took much longer. So the kinetics of the antibody response was different. And even after 2 doses, a subset of the patients did not have any antibodies. And this was quite surprising to us. So we went in to investigate further what was the clinical feature associated with this feature or features. And we found a couple of interesting things. One was if a myeloma patient had previously been exposed to the COVID virus by natural infection, they mounted a much higher antibody titer, almost comparable to healthy individuals. Thankfully, the vast majority of the patients were not exposed to COVID, and these were actually having lower antibody levels. The second thing that we found was that the antibody levels in patients that were on anti-CD38 therapy with or without other drugs was much lower, and they tended to have these absence of antibodies much more often. Similar to this, patients that were on anti-BCMA therapeutics, both CAR T and bispecifics, had much lower levels as compared to other myeloma patients or patients who are not actively getting treatment. So these were the patients which formed a vulnerable group and we showed a difference in antibodies, but we wanted to know, was this difference clinically relevant? I mean, was it just a number that we were looking at on a report, or was it actually associated with the risk of getting COVID? And indeed, in a short span of when we collected the data, we had at least 10 patients that had developed COVID-19 infection despite getting vaccinated. And you can see the majority of the patients had negative antibodies and were on daratumumab or BCMA therapeutics. And this validated that the clinical relevance of lower antibodies was real. Um, we then went on to study whether, in addition to the antibodies being different, was the cellular backup to the antibodies. And we are supposed to have B cells and T cells that remain as the memory of the immune system to mount a COVID response, even when antibodies may be waning. This has been shown in studies of healthy individuals as being an important second arm of protection. We went on to test this, and we found that patients that were on anti CD38 antibodies clearly were not having even the B cell response. And I'll show you in a second the T cell response. This is one example of a patient on daratumumab who has zero B cells that can recognize COVID even after 2 doses of vaccination. We then went on to study the T cell response. And to do this, it was an incredibly laborious process because we had to isolate first the peripheral blood cells and expose them to COVID antigens that were synthetically manufactured. Thankfully, we were able to get them from a lab in California. And once the T cells recognized these COVID antigens outside the body, they get activated and start secreting cytokines. And in this slide, which we ultimately published earlier this month, we showed the production of cytokines. Cytokines are chemicals that T cells release to help fight infection and activate other parts of the immune system. That levels of all of these cytokines, indeed the T cell response, was starkly different between patients that had antibodies against COVID when we measured them in the blood, or patients that did not have antibodies when we measured them. The patients that were seronegative, that means they didn't have antibodies, had lower T cell responses as well. As you can see in this graph on the bottom left, there was a good correlation between the patients that mounted an antibody response and patients that mounted a T cell response. So if you had antibodies, you had more than a 90% chance of having T cells. But if you did not have antibodies, 30% chance. So a big difference in the odds of having a T cell response. And when we looked at the treatment effect, again, an interesting correlation emerged. Patients that were on anti CD38 antibodies had a much lower chance of having T cell response. And the patients that were most vulnerable were patients that were on investigational anti BCMA bispecific antibodies that had the least T cell responses, uh, possibly because their immune systems are getting constantly bombarded with antibodies that deplete the factory of plasma cells and B cells that we need. Our research is now focusing on the current question in the myeloma community, which is what happens after the booster vaccination. Most of our patients have now been encouraged to receive booster vaccination and indeed have received booster vaccination. So I'm going to try to address this in a couple of slides. This is an example of a patient of ours who received 2 doses of Pfizer vaccination and was on daratumumab based therapy. And after the 2 doses of vaccination, failed to mount an antibody response. And she was getting increasingly worried over time as there was still no immune response many months later. And being very resourceful, she called around and found a pharmacy that was able to give her the Moderna vaccine even a few weeks before all the boosters got approved. And when you see her antibody response, you can see it shoots up after this vaccination and really not only mounts antibodies, but she also mounts a cellular response to her. We were able to detect both B cells and T cells after her booster vaccination. So it was really encouraging to see this data in a live individuals. Um, we've shown that serological response, antibody responses, are highly variable in myeloma, particularly in prior COVID infected myeloma patients, the antibodies are higher, and about 15% of patients have no antibody responses detectable even after 2 doses of vaccination. This group is enriched for patients that have anti-CD38 based therapy or anti-BCMA based therapy. And this same group is associated with having lower T cell responses. So they need to be extremely careful. They need to remain vigilant in terms of masking and social distancing. And I will give you some other ideas on how to have protection. But the most important protective measure that we have available right now is the booster. And this data that we have generated is useful for myeloma, but may help even other immunocompromised patients, patients with lymphoma or chronic leukemias and other diseases that have similar immune suppression. The consequence of this on our practice has been that we are testing very routinely now for COVID antibody levels in our patients. In some patients, we are even choosing alternate chemotherapy if we think that they are particularly vulnerable to COVID. We may recommend other options to them. We are timing our vaccination a little bit better. So clearly, we learned a lesson from CAR T, for example, that giving the vaccine too early is not good for the patients. We need to wait a little bit till their immune system is ready to recognize the vaccine and mount a response. The booster vaccination, I cannot stress enough, is the most important thing that we are encouraging our patients. And I'm happy to say majority of patients have now received the booster. Wherever possible, we are trying to perform B and T cell assays. It is not easily to do available or easy to do on all patients, but we are trying to raise funds and do this. And another important thing, which is a very simple but practical point that I want to remind patients, is that we should encourage our family members and friends to also get vaccinated to create a bubble of protection. This is going to be extremely important, especially now around Halloween and Thanksgiving and Christmas. You're going to try to get together, and having this bubble of vaccinated people actually reduces your risk of getting severe COVID as well. And with that, I will just say thanks to the entire lab team and collaborators that helped with this endeavor, including Oliver, Adolfo, and Bhaskar. They were supported by a very good clinical coordinator team led by Sarita and Katerina. And I've listed all the physicians in the group led by Sundar Jagannath. We have a number of collaborators at Sinai in the Precision Virology Institute. Viviana Simon was absolutely key to this effort. She led the microbiology lab and has actually enlisted all the doctors and nurses as well onto studies to serve as healthy controls for these types of studies. Anya has supervised the vaccine rollout at Sinai, and Florian is a famous virologist that has helped create the test, which was implemented by our head of pathology, Dr. Carlos Cardon. We also have had a lot of help in this journey with our immunology colleagues, led by Miriam Mirad and Nina Bardwaj, and an excellent immune core led by Sasha Nyatik and Sunghi Kim Schulze, as well as Brian Brown, who's an internationally recognized immunologist. And in fact, we are part of this ZeroNet study group, which is a national effort at trying to understand the immune responses in different groups of patients. And without the participation of the patients and all these funding agencies, this sort of research would not be possible. So we're extremely grateful to them. And with that, I'll stop the slide presentation and maybe switch to question and answers. Audrey, do you want to moderate us? And Oliver is very knowledgeable as well, so we can ask him a few questions, and I'll try to answer a few.
Great. First of all, let me just say thank you for providing us with that knowledge. I think it gives a lot of information and light to questions that we've had for a long time. And I also just want to say thank you for letting us know also how difficult the process was, that it wasn't, a super easy, oh, we just look at this and then get the answers. I mean, this took a lot of work, a lot of time, and a lot of people. So thank you to all of you for putting in that time and effort. There's a lot of questions, great questions, and there's several themes going on. So let me try to go over the themes and then we'll try to hit individual questions. So not sure if you guys heard, but they recommended a fourth shot or a second booster vaccine this morning. What are your thoughts on that?
I'm happy to say something on that. So first of all, I want to thank the Myeloma Crowd people for having us here and allowing us to have this conversation. And I've checked the Q&A, so there's some very exciting and very good questions. So and it's very timely because, as you said, this morning there was the announcement of the perhaps a fourth dose strategy. I think it's important to say two things to that. First of all, I think a part of the philosophy behind the strategy is what was shown by Dr. Parekh as well, is that there's a number of people who got their 2 shots and had no antibodies whatsoever. And then in some patients, or at least the majority of the patients, about 3/4 of them, we see after the 3rd dose, we see the antibody response come up. But we know from basic immunology, and it's a little bit technical, that the immune response gets stronger if you have this, very often if you have multiple exposures. And so I think part of the reason why they want to do or to explore the fourth dose strategy is to give patients that had no response after 2 doses, but have transitioned to a seropositive state after their booster shot or their third dose, to give them the opportunity to have more durable responses and high quality antibodies as well. To be honest, we have no data yet, at least at our center, because it hasn't been approved. But I think we're very excited if they endorse it, and if it's going to be necessary, we'll collect the samples and try to report as soon as possible whether or not we see more durable responses. But yeah, that's how I feel about the 4th dose, at least.
Sure. I'll just add a couple of things to that. I think the 3rd dose, or the booster, as we call it, was approved in immunocompromised patients, including myeloma patients, based on a report that was published in the New England Journal on organ transplant patients, where they had seen responses about 1/4 of the time in patients that had 0 antibodies. So it was not perfect, but it was something that gave hope to us. And on the basis of that, the FDA and CDC reviewed the data and recommended extending the protection to other immunocompromised patients. So I think that even after the booster, there may be some patients that are still not mounting adequate immune responses, and the 4th dose may help, as Oliver mentioned, in getting all of us there. And that's one aspect of the thing. The second is that so far, we have not shown or experienced any patients having a negative effect of having a high antibody level. So there seems to be no downside if you have a very high antibody of having more side effects from myeloma or side effects from chemo. The patients that have an antibody level of 2000 behave the same way as patients having an antibody of 200. And as long as they are above the threshold of protection, they all seem to have a decreased chance of getting severe COVID. So this is what I think is important at the end of the day and what we are trying to achieve.
Definitely. Yeah, that's an important observation. Thank you.
Yeah, and there's one more thing I'd like to say to that as well, and I think it might come up in the questions later as well, but I mean, there is obviously, because we were first exposed to COVID about like in early 2020, and so we have imperfect data as well there. There's a possibility that, like the flu vaccine, we might have to go for an approach that, for example, says like a yearly vaccination, especially in patients that are immunocompromised or they're getting treated with agents that might suppress their immune system. But I think the same might apply to healthy people as well, because these respiratory viruses, I mean, COVID as a virus is different from the flu, but if you think about it, even to regular coronaviruses that cause more mild disease, we're not protected by our own immune system lifelong. So there too, you can already appreciate it might become a strategy where we need to take into account the fact that it's a possibility that we're gonna try to implement a strategy where you have yearly or bi-yearly vaccination with some type of COVID vaccine. I think that's something that will be investigated at least, and that might offer the best protection to especially to patients with serious underlying disorders.
Awesome. Thank you for that. That's been on my mind. So thank you for bringing that up. Another big question that's repeated often is I don't even know if you guys are going to be able to answer this, but the brand, is there a recommended brand for the booster shot? Does it matter? And I think the concern is, do you see any issues if, for example, their first vaccinations were Moderna and they get a Pfizer booster or vice versa? The mix and match method?
Sure. I mean, so I think very recently, also last week or something, they finally came around and said like, okay, get a booster. Don't worry too much about whether or not you're mixing two types of vaccines. I think that was a very wise advice. I think it's more important that, as Dr. Parekh stressed, that people get their third dose or their booster shot rather than spending time trying to get a particular type of vaccine. Mm-hmm. In our experience, most of the patients, they're well behaved, and so they followed the recommendations, and they took this for their third dose. They took the same vaccine as they did previously for their first two doses, and that was very effective. Whether or not it was Pfizer, whether or not it was Moderna, we had even a couple of patients with J&J or got a third dose from the J&J. In almost all of the cases, that led either to a strong increase of the level of antibodies, and in the patients that had no response after two doses, 3/4, as we said, were able to mount detectable antibodies after a third dose, regardless of the strategy that they were following. In our big cohort of antibody levels, I think there was no statistically significant difference between, we only studied the RNA vaccine, so the Pfizer and the Moderna, and there was no statistically significant difference in their efficacy. There was, I mean, numerically, there might be slight differences, but at least in terms of the level of protection, or if you look at serious consequences, there was no statistically significant difference. So the bottom line for me would be to get the vaccine that is available as soon as possible. I think that's the strategy that I and most people in our team also followed. And I mean, that's more important than the particular type of vaccine, in my opinion.
Did you have anything you wanted to add, Dr. Parekh?
I have a strong endorsement for vaccine brand. It's the vaccine brand that's available fastest and closest to you. You need to get it. That's the important thing.
Good. People are wondering, the study that you showed the Moderna booster vaccine. Do we have any data, because it was just so recently announced 2 weeks ago, about that Pfizer booster vaccine and its efficacy, or would it matter?
Yeah. Yes. I mean, yes. Short answer is yes. Longer answer is I think Dr. Parekh showed the case report of one of our patients, and she switched from Pfizer to Moderna because she did it also before the boosters were really a thing. And so I think that's why she took the other one and kind of as convinced people to give it to her. The data that we showed later was on a bigger set of patients, the ones that either went from 0 to 60 units per milliliter, as well as patients that went up. Most of them were Pfizer or Moderna. It's a good mix of the both of them, and as I said, a handful or so were treated with Johnson & Johnson. It's a smaller subset. I must acknowledge that, because I saw there were some questions from people there as well, and it's harder to make strong claims because we have less. I mean, the number of patients that we have with the Johnson & Johnson vaccine is more limited, but there too, I think there's data that is strong, that's been presented by the company, that suggests that it's important for them to get the second shot for sure, and perhaps even a couple months after you got the second shot, get the third dose, similar to, I think, the strategy that's been used for patients that were initially vaccinated with either Pfizer or Moderna. I think that's probably the most prudent way to go ahead.
Mm-hmm. Thank you. All right, we have a good question from Paul that I wanted to make sure that we brought up today. His question is, why would I get the vaccine if I had COVID very mild? And supposedly I have antibodies. There have been he's had smoldering for almost 4 years, and he's just trying to understand why he should get the vaccine.
Yeah, so I think that the natural COVID infection does boost antibody levels and create some immunity. We just don't know enough about it to say that it will create it for a sustained amount of time and create enough immunity that it will be protective. So the vaccines have been tested in that manner. And again, to be doubly sure, I would still encourage patients that have had prior COVID to be vaccinated. At our center, what we've recommended is that patients wait for about 3 months or so before they get their vaccinations, but they do end up still getting them. And this is even more important for patients that are on treatment.
Okay, that was one of the questions as well. If I'm not on treatment and have a precursor condition, is it important for me to get this booster vaccine? So thank you for that. Several patients are wondering if you could repeat the timing of when we should get these vaccines after stem cell transplant and CAR T. What's the recommended timing?
Yeah, so there aren't firm recommendations yet. There's an ongoing BMT CTN study that is looking at this specifically in the post-transplant setting, and will be able to give us an answer hopefully in the coming months. I think for the moment, the best recommendation that we have is unfortunately to, if you have access to test for B and T cell levels, and as they become detectable, to take the vaccine. This means probably a difference of few months at most in most cases. And this is the best we can do with the information we have now, until we have enough to say there's a firm cutoff of 6 months or 1 year or whatever. We still want people to get the vaccinations, but it ideally should be guided by the immune recovery that is usually a few months into the treatments that you just mentioned.
Awesome, thank you. And I would just say consult your transplant team or your CAR T team about that, as one of your concerns, and make sure you get that information really clear from your treating physicians when that timing will be. One of the questions asked here was, after my vaccine, I saw a slight increase of kappa and lambda light chains. Is this something you guys observed in your patients?
That's, I think, a very good question. And if I understand it correctly, then I think it's not unanticipated. I think it might be a signal that the vaccine has an effect, and so it's doing what it should do, and that is stimulating B cells, which are the cells that are making antibodies and turning them into plasma cells that are actually responsible for generating the spike antibodies that we need, or that we try to elicit by giving the vaccine. And so you can see, similar as to when you would have an infection, you could see the kappa and lambda light chains go up slightly. I think for that, it's important to obviously follow your labs regularly and make sure that it's a transient rise and that it's not a sign of myeloma itself manifesting itself. But if you have a slight increase of things like the kappa lambda light chain, and that was also some of the questions that I saw earlier, you could have, after the vaccine, you could have slight changes in your lymphocyte counts and things like that that are correlating with the effect of the vaccine on your immune system, because it is supposed to stimulate the proliferation of lymphocytes, T lymphocytes and B lymphocytes, as Dr. Parekh showed, that contribute to different arms of the immune response to viruses such as COVID.
Thank you. There's a couple questions regarding this topic, which is when I have, so let me try to word it in a way that's not super personal to the patient. But if they have a good response to the vaccine and then they are treated with something like Blenrep or BCMA targets, does that lower the antibodies that they've already developed? Does that make sense how I worded it?
Yeah, it's a very, very important question. It's a very good question. And it's, I think, also a good segue in something that we should spend some time on discussing. And Dr. Parekh, obviously, you can complement whatever I said. But I think that's an important concern. And it just highlights the fact that, at least that's our philosophy, is that it's important to follow for example, the levels of antibodies. We have done it obviously in the study that we showed, but initially there was a guidance from the FDA that said, like, oh, please don't measure antibody levels because they're not really telling you a lot. And I agree with that guidance for healthy people. I don't think I agree with that guidance for people with serious conditions like myeloma, or even the precursor conditions where you have a very significant chance of not having a strong immune response. And there, I think it's important to consistently measure the levels of antibody. And it's true that there is some variability. I think Dr. Parekh also mentioned this, depending on which lab or which company is the one doing the antibody test. For that reason, I think it's important, again, to try to get it as consistent as possible and not go to different labs at different times, because then you might have a difficulty interpreting the dynamics of the response. But at least if you go to the same labs and you have them determine the level of antibodies, usually you should be able to track whether or not the level of antibody stays detectable and how elevated it is. And I think that's, at least in our experience, a relatively good correlate with being protected against COVID. It's not a perfect correlation. There's patients that might not have detectable antibodies, but that do have T cells. But in general, as the figure that was shown in the presentation, a lot of the patients that have undetectable antibodies also lack their T cell responses, and they're the ones that I think are probably the most vulnerable. And it's definitely conceivable that patients who initially have an antibody response, but they're then treated with things like daratumumab or isatuximab, the CD38 antibodies, or the BCMA targeted treatments that specifically target the antibody producing cells, that they might lose their protection. But then you should be able to detect that, I think, with the lab test, and then decide whether or not it's necessary to repeat the vaccine, or by being it a booster or third dose or fourth dose or whatever we call it, after a couple of months, or preferably in the period where you're not being treated with that agent, I think.
Great. And then I have a couple follow-up questions to that. So if they do notice that their antibody responses are decreasing and they want to stop treatment if they're able in order to get that vaccine, is there a period of wait time that would make the most sense between ending, like stopping treatment, getting your vaccine, starting treatment again?
Yeah, so let me sort of expand on this point.
Yeah.
Some of the things that we found correlated with low antibody levels are easily measurable in the clinics. We can measure the number of lymphocytes, for example. This is done in a CBC test that almost every patient gets before they get treated. Low levels of lymphocytes were associated with lower levels of antibodies.
Mhm.
And this intuitively makes sense because if you don't have lymphocytes, you're not going to have B cells or T cells. And this is probably the underlying reason your antibody production is also lower. The product of the antibodies, that is the immunoglobulin levels, were another surrogate. So patients that had very low immunoglobulin levels were also more likely to have lower antibodies. And in our previous publications, we found patients have worse COVID outcomes, in fact, when they have COVID infection. Uh, in the recent paper this month, we showed that a lower T cell count, which is a CD4 count, also pretty much routinely available, was associated with not mounting T cell responses. So I would say the guidance to patients and doctors who are treating them, who want to time a vaccine better, is to follow simple things like lymphocyte count recovery, immunoglobulin recovery, and then attempt to give vaccination. And this will increase the chances of having a better response.
Wonderful. Thank you so much. There's several questions about how can they get these on antibody levels tested through LabCorp or through other organizations. I didn't know if you guys wanted to speak to that.
I think most major labs at this point offer a test. As I said, there might be some difference between the exact brand or the type of the test, and I'm not advocating for a specific type of test. I just think it's important if you're gonna look at the dynamics, so look at the results over time. It's usually better to have it done in a consistent way so that you can compare and see if the levels go up or down. As to the frequency of testing, I mean, we have patients on our study that have their blood drawn, I think almost monthly and tested. I think that might not be necessary for everyone. I think if you have a test that shows that you have high levels of the antibodies, I mean, you can definitely wait a couple months and just include it in your, it depends on how often people come in, I guess. But if you see that you have high levels of antibodies, it's not necessary to get it measured weekly, I think. Usually we see that there's a relatively slow decline, but it might make sense, especially when you're changing therapies or do it every couple of months to get it checked and see what the level looks like. That being said, I think there were some questions. I think the people that are attending this webinar, they're super knowledgeable, so that's good. And to be fair, it's sometimes hard for physicians locally to give very concrete and clear answers to some of these questions, as am I protected, which level of antibody is high enough. And to some extent, that's because we don't know, and there might not be a perfect answer, because it also depends on other factors, the amount of virus you're exposed to, the level of protection you have from T cell immunity and things like that. So people want to be a little bit careful and not go out and say like, oh, when you have a level of 50, for example, you're safe and you can do whatever you want to do and you're never going to get COVID. I think it's important to look at these numbers and look at them in the context of, or more holistically, look at them in the context of other immune factors, look at them in the context of treatment, and look at them in the context of how vulnerable you are as a patient. Everyone is slightly different, and therefore I think it might not be reasonable, or it might not be within expectation that this one number, the antibody level against COVID, is not gonna be the one factor that determines whether or not you're completely safe. That's, I think, the humility that we as physicians need to have, to be like, look at the bigger picture and integrate all these factors, and everything together, I think, informs or determines the risk that you have as a patient.
Thank you. And I'll just mention in our follow-up email, we'll be including some resources about how and where and when to, or not when, but to get antibody tested. So thank you for that. You said, there are very educated patients on here and lots of amazing questions. And it's, as I go through, one of the commonly questions that are asked is there a threshold of protection? Is there a golden number that says, okay, I have enough, I'm ready to, kind of let loose a little bit more?
Yeah, that number is different from test to test. So that's the first thing you should be aware of. I think most reports that are being issued now are giving some interpretation along with the actual level of the antibody. They either say below this level is considered low or undetectable, above this level is considered moderately strong or very strong. So I think that there is some information given along with the level, at least in the reports we give our patients. They have some guidance as this is a strongly positive result, and that is usually when they are well above the threshold of protection. So I would encourage patients to read the report with your physician and get some help in interpreting the specific assay that has been used in your case.
Yeah, I think most companies that come out with assays, such as the one that we use at Mount Sinai, they're getting asked that question by physicians and by the government as well, because it's a very important question. And so many of them have done studies and have published studies to correlate the level of antibodies with things like neutralizing titers, so the level that you need to neutralize specific viral strains. And that information might be out there, but for that, I think it's best to have the discussion with your physician and have them look into it with the report there and the details of the test, because it's hard to comment on that because every test is slightly different. So, but there should be data, I think, at this point for most of the tests to give at least some indication of what level is protective. That being said, like, the caveat there is that also depends on the virus itself, and as we've seen throughout the last 2 years, I guess almost, is that the virus has a tendency to change as well, and so it's not impossible that it might have another change, and that the level of antibody, or the efficacy of the level of antibody, changes slightly, which is another reason why it's hard to comment on the exact level that you need to be protected.
Interesting. That's
so, Audrey, I was just looking at Q&A, and I saw a interesting set of questions around the passive monoclonal antibodies, and I think this is an important suggestion from some of the audience, and something maybe we should talk about a little bit. So I think that for the patients that are vulnerable, and currently these monoclonals are approved for patients that have been diagnosed with COVID and are used to protect them from getting sicker, and they are extremely effective. We do recommend, and we routinely use them when a patient calls us saying, I've been diagnosed with COVID locally, what should I do? We actually organize them to get these monoclonal antibody infusions at our clinic right away. And it has helped many of them manage the COVID infection without hospitalization or getting worse. So we definitely do recommend getting them in the approved manner. And what's interesting is I've been talking to the pharma industry folks that make these antibodies, and they are about to launch clinical trials that will allow us to give the monoclonals as a prophylactic strategy 2 patients that remain immunocompromised even after vaccination. So there is hope that we will, as soon as these trials get activated, actually, I know they've already started doing this in Europe on the other side of the pond, but it is soon coming here as well. And as soon as these trials open, I would encourage those that are interested in contacting their local centers and seeing if they could receive these antibodies prophylactically as well on trials.
Okay, thank you very much. Is there any other questions you saw that you wanted to answer? I don't mean to try to determine, if you see one.
No, I thought that was a good sort of useful question for general use, and definitely we do recommend it. It's safe and effective. So again, like the booster, the passive antibodies are recommended, and they have no seeming downside to myeloma treatment or anything like that.
Okay, thank you. There's been a question throughout, again, that's trending. Does it matter, did you see any responses differ depending on whether they were IgG, IgA, IG, does that
Yes.
matter in your results?
At least in terms of antibody level, we didn't see a big difference. So I think that should be similar. There might be some slight differences, but I think that's not going to be the big changer. Some people also asked whether or not the IgG level could be indicative, and I mean, overall, we see that patients that have very low levels of immunoglobulins in general, they're in a state of what we call immunoparesis. So that means that their immune system is weaker or is less poised to be able to react to stimuli to the immune system. There, it's a slightly higher risk of not responding to the vaccine if you have very low levels of all your immunoglobulins. That being said, it's hard to really put this into a simple recommendation, because as I'm sure many of the people know, if you're being treated, that will suppress the levels of the particular immunoglobulin that your disease subtype is related to. So, but we saw that in patients that have very, very low levels of all their immunoglobulins at the start, that they were at a slightly higher risk of developing no antibodies after the vaccine. So they should be extra careful, or at least make sure that they get checked after getting the vaccine.
Thank you. In your study, did you guys realize or find out how long responses usually tend to last before they start to decline?
Yeah, so because we started collecting very early on, I think that we started almost immediately after the vaccine got its emergency use approval in the beginning of this year. We have data for the patients who got their 2 doses, which is almost everyone in our study, up until I would say 8 or 9 months, which is the timing when most of them get the 3rd shot. And you clearly saw the levels decline. I must say as we saw, there was less of a response in patients that were on an anti-CD38 monoclonal antibody, but they also had a faster decline in the levels of their antibody, and some of them declined. There must be people here on the webinar as well where they saw the antibodies decline until it became totally undetectable. So that's a little bit concerning, and that's one of the reasons why, again, I think it would make sense to have them checked out at regular time points, and then that could also inform when it's time to get the 3rd dose of the vaccine for patients that might not have come to that point. I think most of the patients at this point who got vaccinated early in 2021, they should be at the time point for their 3rd dose. And we will keep collecting the data, at least for the foreseeable future. And so do other people. So do other disease groups that are more or less related, other cancer disease groups. And I think that will inform us as well on the question whether or not it's necessary to get a revaccination after a year, for example, which I think is still in the realm of possibility at this point. If you see I mean, we need to be humble, and we see that the levels decline in many or in most of the patients, even if they don't go to zero. And so in order to keep your immune response fresh, so to speak, it might be necessary to get revaccinated. But that's, again, one of the reasons why we think it's important to track the responses.
Awesome. Thank you for that. There's been some confusion among our patients about whether, booster dose means full dose. Is it recommended this fourth dose? Is it a booster half dose? Can you explain that a little bit more about what is being recommended currently for immunocompromised patients in regards to whether it's a full dose or a booster half dose?
I mean, I think at this point, it depends a little bit on the type of vaccine as well. For Pfizer, I know the third dose, for example, I mean, the terminology matters, so that's true. For immunocompromised patients, like our patients, we technically should not speak about boosters, but we should speak about third dose, and it would probably be fourth dose as well. And so there, at least for the Pfizer, I know the idea was to give a full dosing strategy. For the Moderna third dose, I'm not 100% sure if they recommend to do the full dose, because for the booster, they came out with a lower dose. So that is something that I think is not entirely clear, but in general, the idea was for the third dose to be a full dose, and that's based on the reports that were available at that time when we didn't have these lower doses. I think given the fact that for the fourth dose, for example, the announcement was only earlier today, I think we need to see exactly how they will implement it, and then we will be able to interpret and see what dosing strategy they recommend. But in general, I think for the third dose, the idea is to give a full dose or a full treatment that is similar to the first and second doses.
Awesome. Thank you. I do see some comments as well about people that have had various adverse reactions to the vaccine. And I just want to make sure that we say to consult your treating physician or the people that gave you the vaccine, because you're going to want to make sure to report those symptoms to them so that they can help you in the best way possible. I just wanted to make sure that we made that clear. There's a couple questions, and I don't know how to pronounce this. I should, but it's called Regeneron. It's a medication that's being recommended by different oncologists for immunocompromised in order to treat or combat COVID. Do you guys have any thoughts on this?
Yes, I think when I was talking earlier about the passive antibodies and the infusions, I meant the Regeneron, which is one of the two brands that are, I think Lilly is the other one. But the strategy of getting passive antibodies, either Regeneron or Lilly, is definitely useful in their approved indications, whether it's in patients that have been diagnosed with COVID or that may become eligible by virtue of being immunocompromised for trials and things like that.
Okay. Another question people have had is about Revlimid or lenalidomide. What are the effects of lenalidomide on immune responses regarding the COVID vaccine?
Yeah, that's a very good question, because the drug is considered to be an immunomodulatory agent, so it has not only effects on the myeloma cells, but also on other immune cells. In general, at least in our experience, that treatment with Revlimid was not detrimental or was not associated with less positive responses to the vaccine or to lower antibody levels. And it might actually be the opposite thing, because at least in our experience, Revlimid has definitely a more stimulatory effect on the T cell compartment. It's true that it also suppresses B cells. I think there's some data that shows that from earlier trials mostly. But if we looked at the response in terms of antibodies or in terms of T cells, which are the cellular components of the immune response, we didn't see a suppressive effect. And I think that's also one of the reasons. I think it was a question with someone who said they were getting Revlimid together with a personalized vaccine or an anti-myeloma vaccine. That's exactly one of the reasons why they added, because they believe it might actually be have a positive effect on the immune response and make it stronger. So I don't think there's data that shows that it would be bad for patients that get a vaccine.
Okay, thank you for that. What about dexamethasone or other steroids? Did that have an effect?
Yes, so that definitely has an effect, and we think we think that dexamethasone is one of the drugs that contributes to a negative response. It's sometimes hard to measure because I'm sure the people here know that a lot of our patients get steroids in some form at least while they're having treatment, and so it becomes very hard to tease out the ones that didn't get any steroids and then see how they responded, because in many cases they didn't get any treatment at all, and they might not be a representative for myeloma patients that are getting treatment. I think the bottom line is that we believe that dexamethasone might be contributing to weakening the immune response, and we think that from studies that have happened in other patient groups as well. We've looked at studies in patients, as I think Dr. Parekh mentioned, organ transplant patients and patients with other immune disorders that might just get these steroids, and there too we see that they have a weaker immune response. So, question is how to solve it, and I think I also saw a question come by where the person asked whether or not they should hold their treatment for a couple of weeks in order to create a window to give the vaccination. I think for that, it's hard to give advice here on these individual cases, because that again depends very heavily on what stage your disease is in. And I would encourage everyone to have that discussion. I think I know for a fact that at least in our center, there's been physicians for patients that have very well-controlled disease, no or undetectable disease burden. You could argue, and I'm sure that some people have done it, to hold one of the doses or delay one of the doses and create a window of a couple of weeks to give the vaccine a better chance. But again, that's something that I think I encourage everyone to discuss that with their myeloma physicians, because I'm sure that they would be able to assess whether or not that's a viable strategy.
Yeah, thank you for bringing that up. I want to say, I know sometimes my audience will message me after, oh, I'm disappointed my question didn't get answered, but I hope what you can take away is now I am empowered with more knowledge and I know which questions to bring to my doctor. Even if these two treating physicians, or not your treating physician, but doctors, are not able to answer your specific question, now you know the specific question that you need to take to your doctor to hopefully get it answered. And if you don't, then that's when you seek for a second opinion, if that question it really matters to you. We have just a couple minutes left, so I wanted to finish. There's a couple patients that are worried now about DARA. DARA's keeping my myeloma in remission, but that puts me more susceptible to COVID. What do I do? What would be your advice to them?
Sure. I think that as a myeloma physician, I'm a big fan of daratumumab, and I still do recommend it for a lot of my patients. I think that if your physician feels that you need to continue treatment on DARA, the solution is not to be afraid, but to see if you can get your antibodies checked and monitor what effect the daratumumab may be having on your immune system, and then use that information to then have a conversation with the physician to see what options there may be. And as I mentioned earlier, there is more hope around the corner, as well as more boosters. There are these passive antibody trials that are going to be opening up. Some patients have mentioned IVIG on the Q&A. I think that's also a good suggestion to try to get that, especially in the winter months. We give it liberally to our older patients to protect them from infections. So there are strategies for mitigating the potentially immunosuppressive effects of the myeloma medications. And you should definitely have a educated conversation with your doctors, and hopefully this webinar equipped you, as Audrey said, with some thought-provoking insights to take back to them.
Awesome.
Yeah, and if I can add like one thing to that as well, I think that's very well put, and I would totally agree that I mean, for many patients, I think keeping their myeloma disease in check and in control is probably the most important here. At the same time, we know and we appreciate and we admire the way that many of our patients have been extra careful, knowing the fact that they're highly susceptible to infections, and they've been very, very careful in not going to gatherings or staying away even from near family in order to protect themselves. And that's, I think, why in part it's our responsibility, and we owe it to them to offer things like antibody level testing, so that at least you can make a better risk assessment for yourself and see, I mean, and make sure that you don't take more risk than you're comfortable being exposed to. I think that's one of the reasons why we do all these studies and we do all these analyses to give proper information and to have people that are often very knowledgeable, like the people here in the webinar, a chance to take all this information in and then make a decision and make a good judgment as to how they should proceed in life and how they should proceed with this pandemic still going on.
Thank you. And thank you both. I wanted to finish by reading one of the comments that our patients made. This is specifically to Dr. Parekh, but I'm sure it can be applied to both of you. He said that the article in MedPage today where you were quoted about booster efficacy for MM patients was so timely and helpful. Thank you for doing this webinar. And the thank yous are pouring in now in my chat and in the Q&A. I just appreciate you both. Again, I know this has been a source of anxiety for a lot of myeloma patients and their families. And this research that you've been doing really makes a difference and empowers our patients to be able to move forward during a relatively scary time. So thank you for what you've done and what you continue to do. And we'll stay in contact to hear any more updates you have in your findings. Thank you so much. I'm going to close.
It was a pleasure. Thank you, Audrey, for the invitation. And thanks to all the patients and families who joined and gave us such excellent questions to think about. You are the reason that we do these studies, and you inspire us to do better. So please continue to participate, and we are very grateful to you all.
Awesome. Thank you. I'm going to close with just a couple outro announcements, and then we can be done for the day. I wanted to talk about our upcoming meeting. It's really a once-in-a-lifetime opportunity because we're going to have the privilege to hear from Dr. Jim Allison, who, if you don't know who he is, he's a Nobel Prize winner. He's an immunotherapy pioneer. These immunotherapy treatments that we talked about today, he actually is one of the main reasons that these are available to patients. His unconventional thinking led to the treatments that we now know as immunotherapy. So you will have the opportunity to watch his documentary for free and then come ask him and his wife your questions on November 15th at 3 p.m. And you can sign up today. This is going to be included in the slides that we send out to you. You'll be able to click there and register for this once-in-a-lifetime event. I'm really excited about it and really looking forward to it.
Yes, I can tell you, I've seen the movie and it's fantastic. It's totally inspiring. And he's a real pioneer and a great musician. So you will learn a lot in that webinar.
Yeah, thank you. He's a great musician who's played with Willie Nelson multiple times. So it's kind of fun to get to know him, both sides of him. Tonight we have an event in our minimal residual disease chapter. We're going to be talking about clonoSEQ, which is a very sensitive test and a practical approach to MRD. And then the question of, now I have my MRD results, what am I supposed to do with them, and how will this guide my treatment? Thursday, October 28th, tomorrow, is going to be the importance of clinical trials with Dr. Craig Cole for our African American myeloma patients chapter. And then on Thursday, again, October 28th, that afternoon is going to be our nutrition and wellness for myeloma chapter. We'll be hearing from a dietitian that works at a cancer specialty center about how to manage your side effects with nutrition. Another thank you to our sponsors, Bristol Myers Squibb, Takeda Oncology, Karyopharm Therapeutics, Adaptive Biotechnologies, Oncopeptides, Janssen Oncology, AbbVie, Sanofi, Amgen Oncology, and Genentech. And thank you to each of you for being here, for participating, for your questions, for helping us build a strong Myeloma Crowd community. I appreciate you and hope that you have a great rest of your day. Thank you all so much.
Thank you.